Hi, let's answer the question of how renal bone disease and secondary hyperparathyroidism develop. Let's start with the clinical case presentation. We present to you a 70-year-old woman with chronic kidney disease, CKD, in stage G4. She has a creatinine level in serum of 2.1 milligrams per deciliter, which corresponds to an estimated glomerular filtration rate, eGFR, of 20 milliliters per minute. Now you're the nephrologist and she comes to you reporting newly onset increasing bone and joint pain. The following blood values are conspicuous. Calcium is still within the normal range, but very low. Phosphate is elevated, and parathyroid hormone, PTH, is also elevated. Active vitamin D3 is low, and alkaline phosphatase, ALP, is elevated. Based on these laboratory values, the diagnosis of secondary hyperparathyroidism can be made. So let's talk about the pathophysiology of secondary hyperparathyroidism and renal bone disease to explain these blood values and her bone and joint pain. Patients with advanced chronic kidney disease have severely damaged kidneys. An important function of the kidney is the activation of 25-hydroxyvitamin D3, which is inactive vitamin D3, to 125-dihydroxyvitamin D3, which is active vitamin D3. Vitamin D3 can be formed in several ways. In our skin, precursors are produced through the energy of UV rays. In the liver, these precursors are further metabolized to the inactive form of vitamin D3. The precursor molecules can also be ingested through food and converted in the same manner in the liver. Usually, the kidneys then transform inactive vitamin D3 into active vitamin D3. So what is active vitamin D3 important for? Normally, calcium is difficult to absorb from the intestines, but with the help of active vitamin D3, calcium absorption from the intestine becomes much easier. Additionally, active vitamin D3 promotes the formation of bone material by transferring calcium and phosphate from the blood into the bone. Thus, active vitamin D3 is essential for calcium influx into both the body and bones. It is responsible for the long-term stability of calcium homeostasis. What happens with vitamin D3 in advanced kidney disease? As in this patient with severe kidney damage, active vitamin D3 levels drop. With reduced active vitamin D3, intestinal calcium absorption decreases, bone formation stagnates, and eventually serum calcium levels begin to fall. Let's introduce another player, the parathyroid hormone, PTH. Active vitamin D3 regulates calcium balance over the long term, while short-term fluctuations are regulated by PTH. It is secreted by the parathyroid glands when calcium levels in the blood fall. The parathyroid glands lie posterior to the thyroid gland. PTH production is regulated by a negative feedback mechanism. The more calcium there is in the blood, the less PTH is produced. Calcium mediates this effect by binding to a G protein-coupled receptor on parathyroid gland cells, the calcium sensing receptor. In our case, low calcium levels due to reduced active vitamin D3 lead to diminished inhibition and thus promote increased PTH production to compensate for the decrease in calcium. What are the effects of PTH and how does it raise serum calcium? In contrast to active vitamin D3, PTH does not act on the intestine because it must stabilize blood calcium levels quickly, independent of food intake. It breaks down bone substance, releasing both calcium and phosphate into the bloodstream. Now you might think this would increase calcium levels, right? Almost. There's another important effect of PTH. When calcium and phosphate are released into the blood in equal proportions, the calcium concentration does not significantly rise because calcium and phosphate tend to form insoluble complexes, since they chemically attract each other. Therefore, to effectively raise calcium levels, PTH also stimulates phosphate excretion in the kidneys. Then, serum phosphate decreases. Additionally, PTH increases calcium reabsorption in the renal tubules, leading to a net increase in serum calcium. Let's see how this explains our patient's laboratory values in secondary hyperparathyroidism. It all begins with a drop in active vitamin D3. Due to the decrease, calcium absorption is reduced. However, serum calcium is not severely low, but at the lower limit of normal, because PTH counteracts the drop. The further active vitamin D3 and calcium decrease, the more PTH is released for compensation. In the end, we see a low normal calcium level with elevated PTH. Now let's look at phosphate. Didn't we say that PTH stimulates phosphate excretion by the kidneys in the urine? Why is phosphate still elevated then? The excretion of phosphate is an active renal process. In advanced kidney damage, this function is impaired. Elevated phosphate levels, called hyperphosphatemia, are therefore frequently seen in CKD patients. Why is hyperphosphatemia relevant? PTH secretion is stimulated not only by low calcium, but also by high phosphate levels, since in healthy kidneys, PTH would increase phosphate excretion. In CKD, though, high phosphate develops, which further stimulates PTH production. Bone mineralization therefore decreases, as calcium and phosphate are continuously mobilized from bone into the blood. Let's summarize this part. In chronic kidney disease, patients lack active vitamin D3. This leads to low calcium levels in the blood and decreased bone formation. Hypocalcemia stimulates PTH secretion, which releases calcium and phosphate from bone into the blood. Consequently, calcium is maintained at a low normal level. Additionally, the damaged kidney can't excrete much phosphate, leading to elevated serum phosphate. High phosphate further stimulates PTH production, accelerating bone mineral breakdown. This process is called secondary hyperparathyroidism because PTH overproduction is not caused primarily by parathyroid hyperplasia or an adenoma, as in primary hyperparathyroidism, but secondarily by a trigger, such as hypocalcemia and hyperphosphatemia. Can you already explain the bone and joint pain? PTH induces demineralization of bone, so a loss of calcium and phosphate, while the collagen structure, a protein matrix, remains intact. This loss of mineral content is called osteomalacia. It differs from osteoporosis, which also involves loss of the collagen framework. In this context, osteomalacia due to kidney disease and secondary hyperparathyroidism is called renal bone disease, also known as renal osteodystrophy. In most cases, renal bone disease is initially asymptomatic. However, in about 5 to 10% of cases, joint and bone pain occur due to a weak and insufficient bone structure. Let's review the laboratory values again. Alkaline phosphatase, ALP, is an enzyme that can be elevated when bone metabolism is increased. Although not necessary for diagnosing hyperparathyroidism, it supports the diagnosis. It's elevated when PTH is also elevated. In the end, let's discuss therapeutic strategies. Guidelines support the following. First of all, patients with CKD should have calcium and vitamin D levels regularly monitored. In this case, supplementation of inactive vitamin D3 would be most beneficial, and one could evaluate how much the kidneys can convert into active vitamin D3. If this is insufficient, substitution with active vitamin D3 may be suggested, but with caution, as excess active vitamin D3 can easily lead to hypercalcemia due to vitamin D intoxication. Also, phosphate levels can be addressed. So-called phosphate binders are oral drugs that bind phosphate in the intestinal lumen to reduce intestinal absorption. A final, relatively expensive option might be pharmacologically stimulating the calcium sensing receptor. This can be achieved with so-called calcimimetic agonists, which mimic calcium and downregulate PTH production. Let's summarize. This patient has advanced CKD stage G4 with an estimated GFR of 20 milliliters per minute. Due to the kidney damage, she has developed a deficiency of active vitamin D3, leading initially to hypocalcemia. The blood shows a low normal calcium level though, because the parathyroid glands compensate by secreting PTH. Thus, PTH is elevated, and this is called secondary hyperparathyroidism. PTH releases calcium and phosphate from bone, weakening it and sometimes causing bone and joint pain. Let's summarize again. This video gives no medical advice, but guidelines say supplementation with inactive vitamin D3 is most important. Phosphate binders are also commonly used to reduce phosphate intake. Supplementation with active vitamin D3 is used with caution. As a last resort, calcimimetic agents that activate the calcium sensing receptor could be used to suppress PTH production. If you have any questions, feel free to leave a comment, and I'll see you next time.